Okay, so the topic for this class is the treatment of schizophrenia. Treatment of schizophrenia. First, we're going to start with a neuroscience or a biological perspective, and this perspective really emphasizes genetic studies, looking at family studies, looking at twins, and then looking at high-risk groups also. So if we look at the pattern of schizophrenia within families, children of 1 and 2 schizophrenic parents have respectively a 13% chance of developing schizophrenia. If both parents have schizophrenia, the child has a 46% chance of developing schizophrenia. And this is compared to risk in the general population, which is between 1 and 2%. Individuals with a first-degree relative who has schizophrenia are 10 times more likely to develop schizophrenia. If we look at twin studies compare fraternal and identical twins, with the understanding that fraternal twins share about half of their genetic material, identical twins share nearly 100% of their genetic material. So if there is a higher risk factor with identical twins, then we can say that the risk is due to genetics as opposed to the environment. And that is what we find with schizophrenia. So the concordance rate, so that means if one identical twin has schizophrenia, how likely is it that the other twin will also develop schizophrenia? So the average concordance rate then for identical twins is 46% compared to about 14% for fraternal twins. And the concordance rate tends to be even higher when one of the twins, the twin who has developed schizophrenia, has very severe symptoms. There are also genetic high-risk studies that basically look at children who are born to schizophrenic mothers and are therefore genetically vulnerable to schizophrenia. And research shows that factors that separate high-risk children who develop schizophrenia from high and low-risk children who remain normal, so this is kids who don't develop schizophrenia, factors like the home life, early separation and institutionalization, school problems and criminal behavior, attention problems, and birth complications. So it seems then that children who experience those problems in the home environment are more likely to develop schizophrenia compared to children who do not. Looking further at the neuroscience perspective, looking at brain imaging studies, if we compare brains, as you can see in this picture here, comparing identical twins, so these are 2 twins, this twin unaffected has not developed schizophrenia, this twin who is affected has developed schizophrenia. And you want to pay particular attention to what are called the ventricles. So you see with the twin who has schizophrenia, there are enlarged ventricles in the brain. Additionally, schizophrenics tend to have smaller than normal brain size, particularly in the frontal, temporal, and in the entire brain volume. And this is important because these particular areas of the brain are involved in your working memory and also in declarative memory, so knowing information, and then further involved in the hippocampus as well, which, as we know, is largely implicated in forming long-term memories. Additionally, we see that with individuals who have schizophrenia, there is an overall decrease in blood flow within the brain. And this is a best approximation, so a proxy, an indicator of neural activity within the brain. So there seem to be some significant differences then just in brain activity when we compare individuals with schizophrenia to those who do not have it. Looking further in our biological perspective, looking at prenatal complications. So there is a high rate of birth complications that are seen in many individuals with schizophrenia. And there is a wealth of evidence that suggests that the brain of individuals who develop schizophrenia may have suffered trauma during the second trimester of pregnancy. So let's talk about these prenatal complications. And again, these are correlational, okay? So it doesn't mean that if a child experiences delivery complications, the child will definitely develop schizophrenia. It's just that these things are related or seem to increase the risk for schizophrenia development later on down the line. So preeclampsia, the mother experiences high blood pressure. That's a risk factor. Complications during labor and delivery, hypoxia or oxygen deprivation to the fetus, and we know that this can definitely influence brain development early on. Additionally, there is an increased risk associated with the mother having some kind of viral infection, and this is known as the winter birth effect. And the winter birth effect states that there is an increase in the number of children born during the winter months who develop schizophrenia later on in life, and the increase seems to be due to the mother developing the flu, developing influenza. And it's called the winter birth effect because mothers are, of course, more likely to contract the flu right during the winter months than they are during other times of the year. But it seems that when mothers contract the flu virus, during this critical period of 4 to 6 months, so the second trimester of pregnancy, children are at heightened risk for developing schizophrenia later on down the line. Okay, looking at other examples here of neuroscience, looking at biochemical research, there is a hypothesis called the dopamine hypothesis. Dopamine, as you remember from the biological perspective chapter, is a neurotransmitter in the brain. It's specifically related to things like memory and reward. So dopamine, this hypothesis suggests that schizophrenia is associated with excess activity in parts of the brain that reduce dopamine. And dopamine enables communication between the lower and upper brain structures, between the subcortical and cortical regions. And the major line of evidence to support this hypothesis comes from research on antipsychotic drugs. So, for example, drugs that reduce dopamine activity reduce the psychotic symptoms, those delusions and hallucinations that come with schizophrenia. Drugs that work to stimulate dopamine production actually exacerbate or might trigger psychotic episodes. Additional findings to support the dopamine hypothesis: in individuals who have schizophrenia, the number of dopamine receptors that they have is actually greater compared to individuals who do not have schizophrenia, and the release of dopamine is more pronounced in the brains of individuals with schizophrenia. Okay, so antipsychotic drugs, these are very, very effective, and these Thorazine, Haldol, Seroquel, Risperdal, and Zyprexa are all examples of brand names for antipsychotic drugs. And remember, antipsychotic drugs really aided in the deinstitutionalization movement in the United States in particular, where previously individuals with schizophrenia had to be hospitalized. They had to be put into an institution. When these antipsychotic drugs became widely available, many of these individuals with schizophrenia could actually have their symptoms managed, and so they could be taken out of the institutions and reintegrated into the community. Okay, so how do these antipsychotic drugs work? They block dopamine activity. Antipsychotic drugs are particularly good at addressing the positive symptoms of schizophrenia. So remember, the positive symptoms are the excess or the presence of something that normally would not be there, such as hallucinations or delusions. They're not overly good at addressing the negative symptoms. So remember things like the blunted or flat affect or the poverty of speech. They're not good at addressing those particular symptoms. Additionally, the antipsychotic drugs can have some pretty unpleasant side effects. So first we have tardive dyskinesia. Individuals who have tardive dyskinesia, they basically have like some kind of tic going on in their face, and it happens involuntarily. So you might be talking to someone and you notice that a part of their face starts to move. That's from the effect of these antipsychotic drugs. Additionally, other side effects like seizures, weight gain, sedation, dry mouth, blurry vision, these can all be particular side effects here. Also, with individuals with schizophrenia, we see a very, very high level of dependence on nicotine. So about 70 to 80% actually smoke cigarettes. This is probably the only psychological disorder where a primary care physician or psychiatrist might actually recommend or tell you, keep smoking cigarettes. Probably the only time you'll ever hear a healthcare provider recommend that. And the reason is that nicotine appears to improve cognitive functioning for individuals with schizophrenia, particularly with their ability to sustain and focus attention, and also with aspects of their memory, particularly working memory and short-term memory as well. Okay, so looking at other perspectives and how they explain schizophrenia. So the cognitive perspective states that individuals with schizophrenia pay too much attention. Their information processing functions are overburdened and the nervous system is over-aroused and they cannot screen out stimuli. And there is a lot of evidence that shows that individuals with schizophrenia have poor selective attention and they're very, very distractible. So they also posit that there is an under-attention going on with some individuals with schizophrenia, and this under-attention might actually lead to the negative symptoms of schizophrenia. So over-attention is more related to the positive symptoms, under-attention more related to the negative symptoms. So then cognitive therapy, basically, you are working with the client to challenge these delusions and hallucinations. So teaching the client to test out alternative explanations for the delusions and the hallucinations. You know, is it possible that there are really voices in your head telling you what to do, or is this something that is a false experience? Therapy also teaches the individual with schizophrenia coping devices to deal with these particular unwelcome thoughts. Okay, looking at the interpersonal perspective, we might also call this a family systems perspective. In the interpersonal or family systems perspective, we see that there are family patterns. So there's trouble in the families of individuals who experience schizophrenia. So first, let's talk about this concept of expressed emotion. And expressed emotion refers to what people in a family say to one another. And expressed emotion is based on a level of criticism and a level of emotional over-involvement. So there is a lot of criticism and disapproval expressed in these families, and some studies suggest that individuals who live with high expressed emotion in relatives were 3 to 4 times more likely to be hospitalized again. So it seems that this expressed emotion could possibly trigger a psychotic break, could trigger a schizophrenic episode. Also, communication patterns within these families. This double bind communication, where it's basically a catch-22. You're damned if you do, you're damned if you don't. It's basically a contradictory message, or like a backhanded kind of compliment. So for example, if you say to someone, I'm glad to see you, what you're saying makes, the words, the actual words, make it sound like, yay, I'm happy to see you. But clearly the intonation in your voice, I'm glad to see you, is very sarcastic, right? It's almost like you're saying one thing, but you really mean something else. And so with this double bind communication, then, individuals with schizophrenia start to ignore the verbal and focus only on the nonverbal. So maybe you have your arms crossed there, you're taking a very defensive posture, and they will only focus on those nonverbal cues, and so they develop this suspicion about what people are saying and what people are communicating to them. So then treatment for individuals with schizophrenia can involve working with the entire family to get the entire family to recognize these particular patterns of communication and how they can relate to triggering psychotic episodes in family members. Okay, a behavioral perspective focuses on behavior. And in this perspective, they say that people with schizophrenia have not learned to respond to social stimuli. They respond in a very idiosyncratic way to chosen stimuli, and they're rewarded for their bizarre responses. So the treatment then involves relearning what they call normal behavior. So with direct reinforcement, we want to change behavior by changing the consequences. We might offer a token economy, where you basically give patients tokens for performing some kind of target behavior. So let's say that you want your client to start interacting in a more positive manner. When you see your client approach someone and say, "Hi, how are you?" You give your client a token, right? You give them some kind of direct, tangible reinforcer because you want to see that behavior occur again in the future. With the tokens, the client then saves these tokens up and they can redeem them for some kind of privilege later on down the line. So they could save up, let's say, 50 tokens and redeem them for a pack of cigarettes. Social skills training attempts to reduce inappropriate social behavior by teaching individuals how to interact with other people. So you might teach individuals daily living skills. So oftentimes individuals with schizophrenia can let their personal hygiene go by the wayside. They might not know how to take care of a house if they're living on their own. So you can definitely work with clients to teach those particular things. You might also teach them skills that will help them become employed. Many individuals with schizophrenia they cannot hold down a job. And so this is an immense financial cost, not only to them, but to their families and to society as well. And then essentially teaching them how to interact with other people through social interaction skills. So our final couple of perspectives here, the sociocultural perspective, one particular model is called assertive community training. And so with ACT, we have a multidisciplinary team that works with the client to ease their transition back into the community. So multidisciplinary, this means we might have a psychiatrist, a psychologist, a social worker, we might have psychiatric nurses, all of these people coordinated, working together to make sure that the client gets all of the necessary services to make sure that the client transition back to the community is as seamless as possible. Okay, so multiple providers, getting everyone on the same page, doing the same things. And then there are unitary theories like a diathesis stress model. And so with diathesis stress model, we're basically looking at the nature versus nurture, okay? So nature is the diathesis part, stress is the nurture part, okay? So gene and environment interaction. And according to the diathesis stress model, there are stressors that individuals with schizophrenia experience that make it more likely that they will have a psychotic episode, or even that they'll develop schizophrenia. So you might have some individuals who have a genetic predisposition to develop schizophrenia. So let's say one of their parents already has schizophrenia. They already have that diathesis, right? They already have that genetic likelihood of developing schizophrenia. And then they experience many stressful circumstances in their life. So maybe they're in a family that's very high on that concept of expressed emotion. And so those two things interact, right? The gene and the environment interact to produce the outcome of higher likelihood of developing schizophrenia.